welcome everyone to our, as I said, most subscribed, and so far probably average attendance as a result of our link issues. Thank you very much for joining. We have been running these PHN Insights series. We've done, I think this is our fourth. Our organisation, 360 Edge, is focused on supporting the sector and the health system around helping people with alcohol and drugs through policy reform, research, anything we can do to help the system. My name is Chris Rain. I'm the head of partnerships at 360 Edge. I'd like to start with an acknowledgement of country. I'm in Sydney on Gadigal land of the Aurora Nation. I'd like to pay my respects to elders past, present and emerging, and especially those on the call that across the country and identify as Indigenous. Welcome. So thank you very much for being here. We're, as I said, we're excited. We've what we learned in the last series was it'd be great to have it's great to have someone from one of the PHNs that we work with. So we're lucky to have Charlene Green here today from Murray PHN, who wants to hear your hardest possible questions. And we really want to hear from you. So please identify yourself in the chat box, or if you have a question, pop it in the question box there. We really want to get your questions rather than ours. So anything about this work that we can cover off either now or later, would be great to hear from you. So the agenda for today, I'm going to hand over to Nicole, and who's our CEO. Then she's going to have a quick chat about the context of where this work fits in within the broader AOD sector. Then Dr. Richard Cash will talk about the actual work that we did, and then we're going to have a bit of a Q&A with Charlene from Murray PHN. So I'll hand over to you, Dr. Nicole Lee.
Thanks, Chris, and welcome everyone. Apologies again for the technical issues, but thanks for joining us. I think one of the really interesting, I'm going to say tensions, but that's probably an overstatement for PHNs, is on the one hand, the primary purpose of the PHNs is supporting primary care. And on the other hand, they've also got responsibility for much of the federal alcohol and other drug funding, which is a tertiary treatment function. And so those two areas of primary care and tertiary treatment don't always kind of blend seamlessly. And we have struggled for quite a long time to work out better ways to support GPs to do good alcohol and drug work. One of my very first jobs that I had was working on the WHO audit screening tool development, very long time ago now. And one of the most consistent findings from that research, aside from that it works, was that while GPs are supported to do that screening and brief intervention, they do really well with it and it's really effective. But the minute that support is removed and they're kind of like on their own, the screening and brief intervention significantly drops off. So I think this space in the middle that we're talking about today, joining up primary care and alcohol and drugs, is really one of the biggest areas of impact for both sectors and for clients. We've got this overburdened alcohol and drug system. It doesn't have enough funding. We don't have enough spaces for the people who need it. And there's very few publicly funded services for that kind of middle section of people who might need additional support for their drug and alcohol use, but they don't need that specialist alcohol and drug treatment per se. So we are super pleased to have done what I think is a really significant piece of work for Murray PHN. We've learned lots of lessons from it, and thanks to Murray PHN for engaging us for the work. And also Charlene, thanks for coming along to the webinar to answer hard questions. So I just wanted to say that I think this is really really important, has lots of implications like right across Australia, and for improving service delivery for especially that group in the middle. So I will stop talking and I'll hand over to Richard to talk about the recent project with Murray PHN that was aimed at linking up alcohol and drugs and primary healthcare, and then we'll move on to hear from Charlene and also any Q&A and feedback. Thanks, Richard.
Great. Thanks, Nick. A pleasure to work with you, Charlene, and for Murray PHN. I might just give a very brief bit of background, because I think the geography is pretty important, and probably something that a lot of PHNs would have in common is looking after a really broad geographical spread with different patterns of service delivery, different kind of strengths in terms of how networks work, different resources, different patterns in terms of turnover of the workforce within primary care and AOD. But it's a big swathe of Victoria that Murray PHN looks for. It's the Northwest, Central Victorian, Goulburn Valley, Northeast regions, just under 650,000 Victorians, Australians. And the kind of motivator, I guess, for this was, are we supporting GPs to do the best possible work in those brief interventions, quick interventions, making referrals, screening, those kinds of roles that are appropriate within primary care? And also, where are the communication, referral, liaison, awareness, knowledge gaps falling down between primary care and the specialist AOD sector? So that was kind of the brief. Let's bring those two important health domains together with the ultimate aim of improving outcomes for people with alcohol and other drug treatment needs in the Murray PHN area. So we did a few things for this project, and they might seem a little bit disconnected, but I can assure you there was a rationale behind all of this. So the first one, which is very practical, was reviewing and updating the online knowledge resource for GPs. So this is the Health Pathways resource, which is online. GPs use it to get rapid access to information about a management of a whole range of different health conditions. The bit of it that we looked at was the specific information about assessing and treating and managing alcohol and drug problems. So we did a complete revision and refreshed all of that information. Essentially, is it up to date with respect to best practice? Are the information resources and links all current? And stepping back a little bit and thinking about what GPs need to do to be effective, are there any areas which need to be added? So we did that update, and we focused a fair bit on, in a stepped care sense, those harm reduction, harm minimisation screening steps about what would equip GPs to work with a range of service users and patients, essentially, not just people who need specialist referral, but people who might benefit from a light touch intervention. So we added some of that information in so that Health Pathways resource is up to date. The second part is we thought, what is available to improve communication, liaison, connections between primary care and the specialist alcohol and other drug sector? So lots of things go into that. How aware are people of what's out there in terms of services to support clients by way of referral? What are the kind of information transfers, at one level about who's out there doing what, but at a more patient level, what are the information barriers to good clinical communication between the two sectors around things like shared care? So we ran a series of consultations with specialist AOD. We drew on some additional resources about GP insights and needs, essentially focusing on what are the mechanisms, what are the facilitators, and what are the barriers. And we'll get to those in a tick. The last bit we looked at is we looked at the referral pathways between primary care. And for those of you not in Victoria, we have a centralised intake system for our alcohol and other drug services. So essentially that initial screening initial kind of suitability assessment, where would you best be supported in your alcohol and drug treatment needs, is done by a central agency, ACSO. And there is a possibility for a few information breakdowns between a GP trying to refer into specialist AOD, someone getting that initial screening, getting into treatment, and then returning to the community. So we looked at those communication pathways and thought about how we could tighten up those processes, essentially to try to get more appropriate referrals and better communication, better clinical communication between those players in that chain of help seeking and treatment provision. So those were the 3 bits. What did we find? So let's start with the enablers. What helps the sectors to work well together, to be aware of each other, to effectively use each other? And one certainly is resources. This was the health pathways component essentially, but GPs having ready access to good quality information, not just about how do I do basic low touch interventions, to improve that kind of familiarity or willingness or readiness to do low threshold interventions. But if I need to find out about services or how to access them or what different services offer, I need a resource. So that resource element is a critical enabler. Secondly, the people, and this is people with understanding around alcohol and drug treatment and the sector and what appropriate referrals look like. So this is certainly within primary care, almost always though important within the PHN and within the specialist alcohol and drug setting, so that people know about how best to engage with GPs at a practice level and individually. And some of the challenges we'll talk about with respect to people. The last one is good mechanisms, good linkages, and the PHNs play a pretty active role in supporting a lot of these linkages. So we spent some time mapping what is it that the PHN does to bring people together in forums, in professional education, professional development, training workshops that raises awareness, supports the sectors to understand each other, helps develop relationships. That's kind of like a constant maintenance of maintaining those communication links. Good at a sector level, often quite important at a patient or client management level. So some of the challenges we found, certainly think about how people will come in and out of regional areas as both alcohol and drug specialist workers, but also GPs, primary care workers. So we do tend to see a kind of an attrition of knowledge about how the sector works in a particular region. So that turnover was a big one. Limited knowledge was a big one as well. GPs not knowing either what types of treatment are out there, how best to treatment match, how best to access an appropriate referral pathway. We saw lots of opportunities for communication breakdown. For those of you having a Led Zeppelin intrusion at this moment, you're not the only one. But referral information, awareness of the services, unless we keep paying attention to those communication pathways, they can atrophy. It only takes a few people in a network to drop out and suddenly people aren't talking to each other. Just to give you one really specific example of this, communication breakdown really affects us referrals. GPs might make a direct referral to a service in Victoria and essentially circumvent that centralised intake system. And that can be expedient for the GP. Working with someone, I want to know where I can send them. I'm familiar with a local service, I'll send a direct referral through. But that means the service is then stuck with often an incomplete initial screening assessment. And so they have to send that person back through ACSO, the centralised intake, to get that first intake screening done. It may be that the GP's referred someone to a service that they're familiar with, but might not be the most appropriate service for that user. Awareness of who your GP is tends to drop off. There's multiple opportunities for people to go through the centralised intake, to go to a service and to not have contact details for the GP, which means the GP is out of the loop, isn't aware of treatment outcomes, is limited in the role that they can play in things like aftercare. So improving that carriage or that transfer of who your primary care practitioner or even the clinic that you've attended and you're likely to be discharged back to, carrying that information through someone's journey from intake to screening and treatment and then discharge is a really significant opportunity to improve those communication breakdowns. A big and fundamental one would be stigma. And part of the reason why we focused on low threshold and harm reduction in the resources is to reinforce the idea that not everyone who needs alcohol and drug treatment is super complex, and that primary care practices can play a really important role in some of those people with less complex issues. So that's reducing that kind of primary care side stigma around working with alcohol and drug clients. And then the systemic challenges, which is time, and time is money, but essentially GPs not being able to adequately pull back some of their time through MBS items around things like screening and referral. And this sort of alludes to one of the factors that can support this, which is practice nurses supporting some of these screening, some of these referrals, some of these supporting people into specialist care activities. So just zooming back a little bit, we provided a referral pathway structure for Murray PHN to take a role in ensuring that AXO, the main centralised intake in Victoria, and Murray are sharing information to make sure that those communication breakdowns are less likely to happen. But the big outcome for this really is a kind of a monitoring and evaluation approach, a way of thinking about what are we trying to achieve here, which is better shared care, better inter-service or inter-sector communication and cooperation. And just to focus on a few of the impacts that we expect work like this to provide for the PHN and for their regions, we want to build and maintain that connectivity over time between the two sectors. We want to improve primary care's understanding of alcohol and drug treatment. So they're making better, more appropriate referrals. They understand how to access treatment, and they play a better role in things like continuing care or relapse prevention or aftercare because they're getting information about what the outcomes of treatments are. We want to improve the efficiency and the appropriateness of referrals. That's a really big one. Not everyone needs to go to rehab. Lots of people would do much better with low threshold treatments. And we really expect through this that overall patients and clients will have a better experience of accessing specialist services through seeing a GP. And I think I might have gone a bit over time, so I'm going to be quiet there. And maybe turn to you, Charlene, and say you're the recipient of this work. It's all very well for us to think it was helpful, but it'd be really good to get some of your reflections on how you're thinking about implementing and what some of the benefits that you foresee are.
Awesome.
Perfect. Thank you. You want to fire some questions at me, Chris?
Yeah, thanks, Richard. And yeah, again, thanks for sharing your time with us, Charlene. And it's it's really great to see this being shared across the PHN network, these insights from these projects. So, and getting your unique perspective is critical to that. So, just before we jump into questions for Charlene, we'd love you all to post any questions you have specific to this particular problem and this project. And either Charlene or Nicole or Richard can answer them depending on the nature of the question. So yeah, over to you, Charlene. What was really important about this project, and why did Murray PHN kind of pursue this path in looking at it?
Look, I think this won't be unique to anyone who sits in PHN land, but there is that constant challenge between the primary care setting, our GPs and our service providers, and I guess bridging those gaps. And I think, one of the main benefits of this project and why we looked at it is in the Murray PHN region, we showed the map before, we're in rural and regional areas. So we've got limited GPs, we've got GPs that are siphoning through. They will get to know an AOD service and then they'll just make direct referrals there rather than going through that central intake process. So again, as we've already alluded to, what that often means is that they're being referred to a treatment that they don't necessarily need, or it doesn't meet their needs and goals. So what we were looking at was how can we improve the communications between the sectors so ultimately we can get better client outcomes. So I think that is our hope with this project, is that by improving those communications and those relationships between the two sectors, we will have more referrals going through AXO and people will actually end up at the place they need to be. There'll be better continuity of care and people will just get better outcomes. I think the other main thing that was really fantastic for us, and it actually ended up being a bigger part of this project than what we had initially thought, was the health pathways review. So, health pathways is our Bible, really, in terms of for our GPs. It's where we tell them to go. It's got all sorts of resources on there. We were actually looking at reviewing our AOD pathways anyway, so this project was really timely. And I think when I started meeting with Richard and the team at 360 Edge, we had a bit of a look at it and discovered that some of the language wasn't wonderful on our health pathway. It wasn't really a harm minimisation focus. It was quite outdated and a lot of the links weren't the most appropriate. So I think, that pathway is something, now that we've got the structure for it and we've got the appropriate language in there, that's something that we can continue to update on a regular basis. And that's where our GPs go. We get comments from GPs all the time that they love having health pathways where they can have it up on their screen. They can, whatever issue that their patient is experiencing, they can click on it. They've got up-to-date information. It's broken down by our regions. So whether you're living in Mildura, Shepparton, Albury, it doesn't matter. You're able to access real-time information about the appropriate supports there. So I think that's been great. I guess the other thing that we're hoping with this project is by developing those relationships a bit more between primary care and the specialist AOD services. Again, those relationships will develop and then there'll be more opportunities, particularly in rural and regional areas. If you know someone in a service, you're more likely to pick up the phone and request a secondary consult. If you're not sure, if you're thinking, oh, do I need to refer this person somewhere, or is it something that I can sort of manage within my realm of supports? You'll pick up the phone and have that conversation. So we're hoping again, but by fostering those relationships, that more of that will happen.
Amazing, thank you. And what's the the next steps for the project? Like, where do you see it going? Over the next sort of 12 to 24 months.
Yeah, there's a couple of things we're looking at. So we have a workforce development team at Murray PHN. So one of the first things that we're hoping, and we're actually working on it at the moment, is a session for GPs, practice nurses, practice managers with a focus around AOD. And what we're looking to do is actually have AXO come and present. So they'll do a bit of a presentation around, who they are, what they do, but really focusing on the benefits of going through AXO as opposed to a direct referral to a service provider. And those sort of sessions have a networking opportunity as well. So, the AXO staff will be able to meet the GPs. We'll invite the specialist AOD services along as well. Hopefully they'll get in a room. We'll probably put on some food because that's usually a really good way to get GPs to come along to that. So that's one of the first things we're looking at. One of the things that AXO identified as a bit of a barrier to some of this work was having up-to-date contact information for our practices across the region. So that's actually something that Murray PHN does already. Twice a year, we sort of update. We've got a master list of all our practices, who the practice managers are, not necessarily contact details for individual GPs, but we have that practice information. So that's something we're looking at doing, is actually sharing that list with AXO so that at least they've got, they might get a referral for somebody and it's just got, might have a doctor's name, but they don't have that contact information. So if they know the practice and we're able to provide them that information, then at least they're able to follow that up. We also have a team of what we call QUIC, so quality improvement consultants. So they're basically our GP engagement people. So they work every day with our GP practices, understanding what the barriers are. So we're going to rely quite a bit on them really around doing some of this stuff, making sure that we're sharing information. I'm sure all the PHNs who are on the line today, you've got your social media, you've got your weekly newsletters and things that go out. So, we're looking at promoting that information and sharing that as we go. The other thing that we will be doing, we've got an opportunity, I guess. Our current commissioned AOD services, they're due to finish June 30 next year. So we'll either be going through an open tender process or we'll be recommissioning those contracts. So I see that as a really good opportunity to build in some of the recommendations from this project. So, you know, all of those contracts have KPIs in them. So we'll be able to add some additional KPIs around, you know, that communication back to GPs from the AOD service. You know, we'll be able to put some targets and things in there. We haven't got to that yet because obviously it's only July and we'll be doing that work in the new year. But I think that will be a really good opportunity for us to take this report that we've got from 360 Ed, look at the recommendations and go, okay, how can we influence some of this via our commissioned activity? And the other thing is that we're doing at the moment in Victoria, we've got a new mental health and wellbeing workforce strategy for the state. So we're having a bit of, obviously PHNs are commissioned by the Commonwealth. So we're looking at what the state are doing in that space. And then we're going to be identifying what the gaps are and trying to see where we may be able to fit in with that. So bit of a disclaimer, I don't actually work in our AOD space at Murray PHN. I stepped into this project because we didn't have anyone in that role, but we do have an AOD coordinator now, and she's doing a little bit of work around workforce and working with our funded providers around looking at the peer workforce and looking at sort of training and development for those managers and team leaders. So yeah, I think we'll be looking at that as well, but how we can support the workforce, because as Richard already identified earlier, it's a massive issue everywhere, particularly in rural and regional areas. Trying to, you know, attract and then maintain that workforce is really challenging.
A quick question is from one of the attendees is, due to privacy, do you only share what's publicly available, or how have you thought through that as a challenge?
Is what available, sorry?
Due to privacy, do you only share what is publicly available, or are there kind of, you know, private kind of information that you can?
Yeah, so we'll only be sharing. So we have a list of the practices. So what we have would be publicly available, but we've got it all condensed in one list and it's up to date. So those quality improvement consultants, as a regular part of their role, they all have practices attached to the individual workers, and that's sort of part of their brief, is keeping that up to date. So we won't be sharing individual GP email addresses or anything. It will be the practices. But we will, you know, and that's going through our internal governance process as well, just about how we do share that information. But yeah, we certainly won't be sharing any confidential information.
Awesome.
And it doesn't trump what a service would do about obtaining sort of individual permission to share information with health providers. If I could just be sneaky and go back one little bit, Charlene, I think that point about turnover isn't just in these sectors. It's also something that affects the work of PHNs, because that knowledge, you know, what are the top 5 barriers and enablers kind of thing, that knowledge can go with someone who's AOD experienced. And I think that would be a challenge as well, is how do we remember what we know works or what we know is challenging, and we have to keep the preventative maintenance up. If you lose someone who's experienced within a PHN, that awareness.
And that's exactly what happened with this project, Richard. So the coordinator with Murray PHN who initiated this project, very experienced, worked in AOD services for a long time. She went back to direct service delivery and it took us probably 6 months to recruit to that position, which was why I picked up this project, because I had a little bit of capacity, but my background is mental health. So, you know, Richard and the team at 360 Ed were very patient with me when I asked lots of stupid questions initially about this, because, you know, it wasn't my day-to-day work. But now we've got someone in that role who, again, has come from that service delivery. But I think it's a challenge for PHNs generally anyway, is, you know, how we hold that information and how we, you know, keep it alive, and it's not just dependent on individuals.
You bet.
Another question here is around the idea of evaluating improvements in connectivity, and kind of thoughts around that. And perhaps there's, you know, other people in the chat that are looking at this and thinking of data points that might be helpful too. So feel free to pop it in there. But yeah, Charlene, any sort of thoughts around that or insights from the work that you're doing?
Yeah, look, I think it's early days. I think, you know, we're initiating some of this work, so I don't know that we'll start to see the results just yet. I think it will definitely come. I think through our AOD coordinator, through her work that she does in managing our commissioned activity in AOD, this will sort of become like, we have a monthly contract review meeting. So some of these conversations will actually take part of that. But I think those enhanced relationships between Murray PHN and AXO as that central intake point will also be a really telling factor. So, we'll look to have a semi-regular catch up with them to just, ask those questions. How is it going? What's it look like? We've also just, in the last couple of months, we've restructured, as PHNs do, and we now have a new strategy team. So they're sort of getting their heads around what it is, what they do and how they intersect with the other parts of Murray PHN. But I think certainly this, setting the strategy and then evaluating how that strategy is working, this will be something that I'm hoping we can sort of not delegate to that strategy team, but that we can incorporate into some of their activities so that we're monitoring the effectiveness of the project.
And probably worth throwing into that as well, if we did add something like, has the GP been communicated at point of discharge into a service level agreement, we'd have a pretty hard factor on what the specialist services are playing. I think, are we doing shared training and professional development? What mechanisms in place and how regular are they for those liaison, the forums and such that we identified? So there's a range of things that can probably be counted as process. Has this happened or not? Because this is a kind of a known facilitating step. And then I think it's the numbers of inappropriate referrals that would go through to services and the frequency with which GPs are included in part of treatment and discharge planning would be really critical as well.
We have a question from one of our compadres from Western Australia. Can you provide more information on the AXO, please? We don't have such a system over there. Who funds it, and do they refer to community services as well as state, etc.?
Yeah, so they're the big wide funnel really for getting into drug and alcohol services in Victoria, and they do the sort of initial screening, which wouldn't be the comprehensive assessment, but it's the sort of suitability and treatment matching step. And then it's providing a lot of that demographic information about the person and their treatment needs through to each service. They refer to all services and funded by Victorian state government.
So what happened, I'll just add a bit of information there, but what happened a few years ago was for the second time, all of the alcohol and drug services in Victoria were recommissioned by the state government, and they commissioned them kind of separately. So the service delivery arm was commissioned separately from the central intake, which we'd never had before. We'd had a long time ago and then it disappeared. And AXO was an existing organisation that bid on the central intake and won that bid. And so they became the central intake service for the state. That they also provide some drug and alcohol services too, and a range of other forensic services and community services too.
A little bit of holding too, a bit of sort of wait list management for people that have gone through the screening, and if they're sort of reasonably high risk or high needs, they'll do a little bit of case management until they enter the service.
Awesome. So just a kind of final question before we wrap up. Charlene, what's some of the insights that you've kind of gained from doing a project like this that might be helpful for the other PHNs? Both my parents are GPs, so I'm always curious in how you get GPs to do anything. So maybe you have some tips around that are useful for me too.
Can't help you with your parents, sorry, Chris. Look, I think when you're commissioning your AOD services, use the schedules, use the contracts to set really clear expectations about, what is the evidence base, what is good practice, and how will we evaluate good practice. So little side, but in my area, in the mental health space, we redid our KPIs in our contracts this year to have more outcomes focuses. So, what's people's experience and then what's the outcome of that? So rather than just looking at how many episodes of care somebody's had, what has that care actually, what has that resulted for the person? Has it led to good outcomes? So I think, use your KPIs in your contracts, build it in there, make sure it's clear, because then if it's not happening, you've got the leverage to have those conversations with providers about, hey, this is really important stuff. And if we're not doing it, then that's impacting on the client experience. I think, for us at Murray PHN, again, across our region, the issues will be different for the GPs. There'll be different services available. So through your relationships with GPs, get an understanding about what those nuances are, understand what the barriers and challenges, and then look at the work that you do and how you can help bridge some of those gaps. So for us, what the GPs in Bendigo experience will be very different to in Kerrang, where there might only be 2 GPs and there might only be one AOD service. So, know your region, know your pop health data, know your providers, and develop those relationships. Again, like I've already mentioned, use your platforms, your social media, your newsletters, all those networks that you attend with GPs and other primary care providers, promote things, give opportunities for people to come together, because I think it's, again, particularly in rural and regional areas, those relationships are really, really important. And yeah, probably just keep having the conversations, put it on the agenda. Do whatever you can. PHNs, they're all structured slightly different and their teams look a little bit different. And, we've got quality improvement consultants, you might have something else, but identify who within the PHN can support this work and make sure that you're all working together on it. Excuse me, sorry.
Charlene, thank you so much. Really invaluable insights into the challenge. And that kind of brings us to time. So I just want to thank everyone for coming along to the session, and especially to yourself, Charlene, for sharing that. It's a challenge across the sector that we're really keen to keep exploring. So thank you.
Thank you.